this presentation on behalf of my colleague, Dr. Heba Ezzat Hashem. I hope I can give it with the same enthusiasm and dedication she gives in her work. We worked together in both the top subjects, but this was her master degree clinical work. So it's almost the same. And however, in her presentation, she wanted to see the challenge between the different biomarkers that we chose to be applicable in our hospitals, or that we can apply in our hospital. And these were the markers that we chose: CD64 and CD11B, which are neutrophil CD markers; monocyte CD14, which is a surface protein on the monocytes, which also expressed by various cells, including monocytes and macrophage, and also neutrophils, so it's non-specific; and the presepsin, which is a breakdown product of the surface CD14, which is formed by shedding of CD14 from the cell membrane into the circulation, and also by direct secretion from hepatocytes. Actually, presepsin is very promising because as an easy technique, if you don't have a machine, it can be done by dry ELISA technique, which is a rapid cartridge test. However, it's expensive a little bit than the other markers. And nowadays, they have a point-of-care testing machine that can utilize a drop of blood from it directly in the neonatal intensive care unit to detect its level, and it's very promising. So this is most probably our next. Here we aim to answer 3 questions: the diagnostic performance of all the markers mentioned, CD64, CD11B, CD14, and presepsin, the comparison between them, and finally, which panel of marker achieves the best diagnostic performance. In this study, we included 84 patients on 84 evaluations only. Group 1 was the proven sepsis group in 12 patients. Group 2 was the suspected group in 34 patients. And Group 2 was the control group by 38 patients. All the neonates were subjected to CBC, blood culture, CRP level measurements, flow cytometric for CD64, flow cytometric evaluation for CD11B, and flow cytometric for CD14 measurements, and the presepsin measurements. The CD14 measurement was much more difficult to evaluate by the flow cytometric technique because it's expressed on the monocyte. So we needed first a preparatory step, not a whole blood technique, to separate the monocytes and to evaluate the CD14 presence. So the technique was a little bit difficult and consuming more time. The same sepsis criteria were selected, and the demographic data shows a significant difference in the weight, being higher sepsis in low birth weight and very low birth weight. The respiration and the respiratory supports were also significant. Surgical and congenital and rupture of membrane were significant, and the follow-up here in this study, we had a death rate of 43.5%. When we came to evaluate our parameters, the hemoglobin here gave a significant difference between neonates. The CRP, also a significant difference. CD64% and intensity. CD11B intensity only percent was not promising, and CD14% and not the intensity, and the presepsin were all significantly able to diagnose sepsis. When we came to compare them together, we found we identified the cutoff here to be 0.47, not in the other study it was 0.42, and giving us better sensitivity and specificity for CD64. However, if we compare, let me go to the comparison. This is a comparison according to the ROC curve analysis, and we stratified them from the highest to the lowest. We find out that CD64% was the highest, CD11B intensity was the second best marker, followed by the presepsin and the CRP, blood culture, and followed by the other markers which were not significant, such as the CD14 and the both percent and intensity, and the immature cell percent. So when we come to the third question, which panel of marker works best in this kind of evaluation, we found the combination between CD64 and the total leukocytic count were the best combination. Presepsin, if you use it with the CD14 intensity, gives and hemoglobin give us a very good choice with the area under the curve 0.922. Presepsin with CD14 alone also was good, 0.88, and followed up by the rest of the combination, which didn't give us many results. This is the combination we had. The area under the curve was 0.956. However, if you remember from the earlier presentation, the level with CRP was much higher if you use a cutoff value different for the CD64. So we answered here the third question. However, this is a quick comparison about the CD64 with other markers. If we compare it with the CRP, as regards diagnostic performance, technical ability, and the financial, of course, CRP remains the least expensive. As regards CBC parameter, technically it's easy, financially it's not expensive. However, diagnostic performance is not satisfactory. Neutrophil CD11B, diagnostic performance is less than CD64. However, its technical and financial is equal. Monocyte CD14 was diagnostic performance less, technical more difficult. However, financially it's the same. Presepsin, diagnostic performance was less. However, technical, it has the advantage being easily utilized, no machine and no special requirements. It can be now applied as a point of care testing, but financially it remains more expensive. The procalcitonin did not fill any of our criteria. The interleukin 6 and 8 has a better diagnostic performance because they rise very early in sepsis before the CD64, but they drop down sharp earlier. So there is a diagnostic gap between them and the CRP, in which the CD64 fills this gap and help to catch our neonates with sepsis in this area. We still have more questions that needs to be answered. What's about its level after surgical intervention? Some publications says that it is affected by surgery. Others says that it is not affected by surgery, and it can be used to differentiate between different parameters that are high due to surgery and that are high due to sepsis, and this is yet to be evaluated. Its role in non-infectious cirrhosis, it's proven that it is not elevated in non-infectious cirrhosis, being closely related to the neutrophils, which mount the immune response. Its level in monitoring the patient, we evaluated the prognostic value in the other presentation, and we still re-evaluating it again. However, we evaluated the prognostic parameters for the CRP, presepsin, CD14 intensity, and CD14%, and they were all non-significant as regard their prognostic value. So to conclude, still CD64 is the best parameter to be used in our neonatal intensive care unit according to the panel of markers that we used among the 3,000 markers being investigated through all the world. The CD64 and total leukocytic count in this study was achieved the best diagnostic performance. We also recommend the serial measurements of the infectious marker, and after many financial debates and meeting with the clinicians, now we have these markers ready and available within less than working shift to be utilized for our neonates, and we are very happy about that. Thank you so much.
Thank you for the second presentation, which we have given on behalf of Dr. Heba Ezzat Hashem, with the same similar enthusiasm and energy. Are there any questions about this presentation? Yes?
Very nice. Both presentations, very nice, excellent presentations. I might have missed it. How did you come to CD64? How did you come to think of it?
We reviewed the literature. The recent publications, there were only 2 publications before our study that discussed the CD64, so we digged it up and we tried to utilize it.
Okay. Other questions? Yes?
That publication that you mentioned said that it couldn't distinguish between viral infections as well. Did you investigate any of these being viral?
actually, due to the limited number, we didn't prove that the neonates have viral. However, we had 2 cases of fungemia, and the level of CD64 was shooting high above 100. So I think we are still working on it, and still, so since we have it routine now, we can relook it more. It gives you a clue about what kind of infection do you have. If it's a fungal infection or severe infection, gives you a rocking or shooting high percentage.
Okay, thank you. I will give you also the certificate for appreciation and from your colleague.
As long as I'm alone.